Good morning, everyone, and a very warm welcome to today's webinar titled Unseen, Undervalued, Recognizing the Real Value of Informal Care. My name is Svetlana Atanasova, and I'm joining you today on behalf of Eurocarers. Eurocarers is the European network representing informal carers, advocating for their recognition, rights, and better support policies across Europe. If you can just give me 1 minute so that I can admit the waiting participants.
Svetlana, I can admit people if that can help you.
Can you? That would be
Yeah.
great. Thank you. So I was saying Eurocarers is the European network representing informal carers and advocating for their rights. Eurocarers is one of the participants, one of the partners in the Equal Care project. I'm personally very pleased to see a strong interest in this topic, and I'm happy to welcome participants from across Europe. Before we begin, a few technical housekeeping points. So the webinar is being held on Zoom, as you know. Participants are muted by default, I believe. This ensures better sound quality. The webinar is being recorded. The recording is solely for reporting, documentation, and follow-up purposes. It won't be used for commercial purposes. Participation in your webinar, though, implies acceptance of this recording. You are warmly encouraged to use the chat box to post your questions throughout the session. We will address them during the moderated discussion later on. But if you have pressing questions, you can already use the chat for them. We will also be running a live poll later, so please stay engaged and share your perspectives. To support accessibility and multilingual participation, we have participants from different European countries. There are live captions. They're available on Zoom, and you can activate them. So if you look at the bottom of your Zoom screen, you can click live transcript, and then you can select subtitles. And then you can choose your preferred language. Unfortunately, Zoom does not offer translations into all European languages, but majority of the countries representatives from which we have today are covered. If you experience any technical issues, please use the chat and we will try and assist you to the best of our abilities. Now, today's webinar is part of the Equal Care project. Equal Care stands for enhancing gender equality in the disability care sector. The project is a 2-year initiative, 24 months. It's funded under the SERF program, and SERF is an abbreviation that stands for Citizens, Equality, Rights and Values Program, managed by the European Commission. The project responds to a reality that many of us recognize from experience, namely, care work remains deeply gendered, both in formal and informal settings. This obviously has far-reaching social, economic, and personal consequences, and not only for carers themselves, but for society as a whole. Equal Care project aims to address the root causes of the gender care gap by challenging persistent gender stereotypes in both paid and unpaid care. It also seeks to improve the recognition of care work, as well as working conditions and work-life balance of carers. At the same time, equal care promotes a more equal sharing of care responsibilities between women and men. Although the project focuses specifically on the disability care and support sector, the issues it addresses and the tools it will developing are relevant and applicable across the wider care sector. The project brings together 10 partner organizations from 8 countries, including European networks, research institutes, service providers, and civil society organizations. Through this partnership, we work closely with care workers, employers and managers, informal carers, policymakers, and social partners to ensure that care work, whether paid or unpaid, is made visible, properly valued, and fairly supported. So this is the first webinar in the Equal Care series, which aims to highlight the economic and social contribution on both formal and informal carers, and to bring visibility of the often overlooked role of informal carers, who in fact provide the majority of care across Europe. We will explore today why care work continues to be undervalued and feminized, despite being absolutely essential to the functioning of our societies, and why this situation persists across different countries and systems. Beyond raising awareness, today's webinar also seeks to build momentum for policy and structural change at both national and European levels. Today's discussion is not only about data and evidence, it's equally about challenging and changing narratives, long-standing assumptions, and strengthening the case for recognition, investment, and fair and sustainable policies for carers. Now, before we move to the next session, the presentation from our experts, one important final note from me. At the end of the webinar, we will kindly ask you to complete a short online evaluation form. Your feedback will be extremely valuable for us because it will help us improve the future webinars and will ensure that Equal Care Project responds to real needs and perspectives from the field. The evaluation link is already shared in the chat. You can see it on the top, and will also be emailed to you after the webinar. So we kindly ask you to take a few minutes and complete it as soon as you can. Thank you once again for being with us today. Let's now begin the core part of today's webinar, the presentation from our experts. So across Europe, informal carers provide the majority of care, yet their contributions remain largely invisible in economic statistics, undervalued in policy, and insufficiently supported in practice. In this session, we will look at the issue from 4 different perspectives: the scale and role of informal care in the European Union, how its economic value can be estimated, how gender norms shape care responsibilities, and how good practices can help raise visibility and improve support. We will hear 4 presentations offering complementary perspectives from policy, research, gender analysis, and practice. If you have any pressing questions, please post them in the chat and also indicate which speaker your question is directed to. We will collect the questions and address them during the discussion. Now it is my pleasure to introduce our first speaker, Claire Champeux, a colleague of mine from Eurocarers. Claire has extensive experience in EU policy work, research, and advocacy in the social field. Before joining Eurocarers, she worked with several Brussels-based NGOs and local authorities in France, with a strong focus on social inclusion, disability rights, and participation in policymaking. At Eurocares, she is closely involved in work on long-term care, carers' rights, and EU social policies. In her presentation, Claire will set the scene by providing a broad overview of informal care across the EU, touching on topics like who informal carers are, the context in which they provide care, and some of the factors that influence the visibility and recognition of their role. So, Claire, the floor is yours.
Thank you, Svetlana, for the nice introduction, and I'm very happy to be with you this morning and to see so many people joining. I will share my presentation, and I hope to be able to give in the 10 minutes I have a meaningful introduction to the question that you raised. So. Hey, can you see the presentation? Okay, very good. So I must say that some of the slides and what I'm going to say will sound familiar to those who are already connected with European work of Eurocarers, but I found it's useful to restate the basics concerning the way we approach the role of informal carers in Europe, and to introduce our vision to people joining who maybe don't know Eurocarers and the carers movement in Europe. So we are a network of around 77 member organizations, gathering both grassroots organization and carers organization and research organization across Europe. What we're doing is really trying to create a positive. Sorry, I lose my presentation. Yeah, to ensure a positive circle between mutual learning, research, development between our member, bringing facts to the general public and raising awareness and dissemination, but also building bridges between EU level and national and regional and local actors, and make sure we feed EU policymaking with recommendation for policy and action. I think it is important to also to recall that we have a broad definition of informal care that concern all the people who provide regular care to someone, be it for a lack of autonomy or a chronic disease or disability, and any kind of any kind of support that you could provide in this role can be material, but also psychological, administrative support. And we consider carers within the family, but also in relation to other relatives or neighbors and friends. So a very wide definition of informal care. I think this picture tells a lot about the role of informal carers in Europe. If you compare the estimated number of 44 million people being informal carers, so at least 12% of the adult population, which is probably underestimated, who take this role of providing care today compared to the 6.3 million people who are professional carers. I think this already tells a lot. I think Valentina later will come back on this question of the value, the economic value of informal care. It is a difficult question because we know that it's a very valuable contribution that we bring, but it is difficult to estimate. But we have some figure already which evaluates the value of in unpaid informal care in the EU between 2.4 and 2.7% of the EU GDP. This tells that there's no universal long-term care without informal carers. But we have also to bear in mind that informal care is also not only an economic good, but also has a value as an expression of solidarity. It can foster mutual respect and understanding between people, breaking down the fragmentation that we can see in our society. Being involved in care highlights the shared human experience and remind us that everyone has something valuable to offer. And it is contributing to personalized and long-term care, and a long-term care that is also more respectful of the preferences of people needing care. Especially it make it often possible to age at home or stay at home, which is often the wish of people needing care. It is important also to see that carers are from all age groups, all generation. We see that the age group that is the most committed, involved in informal care is the age group 45-64, and especially women. We will come back to this later, I'm sure. But we have also to see that older people are also involved in providing care very heavily, and also younger people. It's more than 8% of the 15-24 age group that is involved in informal care. And what we don't see on this graph is the role of younger carers, because there's an estimation of 4-10% of children providing informal care throughout Europe, with a level of responsibility that is usually associated with an adult. So they might provide care to a parent, a sibling, a grandparent, or any other relative, and are on a regular basis. And this is a reality that is more and more understood, even if we very much lack the proper support of these young carers still. What your carers, in a nutshell, insist on when promoting the rights and the voice of informal carers is that besides all the positive aspects of informal care, it often goes with a triple penalty on the health and well-being of informal carers, their financial situation, because it is extremely difficult to retain a job or to access employment where you have caring duties, and it comes with a lot of isolation. It's also associated with discrimination, and all this is covered by a blanket of invisibility most of the time. So the carers movement is about raising awareness and increasing the understanding of the role of informal carers. We ask for carers to be supported to take care of themselves, to be protected from socioeconomic vulnerability, and to have their voice. This was around the essential informal carers and their need to support. All right. This one around the need to create partnership around informal care. This one was around young carers and insisting on the worry they're facing every day. This one was to show the mountain of tasks and responsibility. This one was around work-life balance. This one was on the role of migrant care in coordination with informal care. And I think year after year, we've managed to support and make it possible for public authorities to better understand and recognize the issue of informal care, which is now clearly articulated in the policy making at the EU level. You can see here during the State of the Union speech, Ursula von der Leyen saying that caring for someone you love is the most precious time of all. So that was the start of the official recognition, I would say, at the EU level of informal carers, and which led to the adoption in 2022 of a care strategy at European level that concern early childhood care and education and long-term care. So in this care strategy, there's a recognition of the role of informal care, calling member states to recognize carers, improve the interface between informal carers and long-term care workers, develop training, counseling, and psychological support for carers, respite care, adequate financial support for carers, and also ensure member states develop the quality, affordability, adequacy of long-term care services and improve the working condition in the services. So all these are elements that we have been asking for, and now the question is, how is it implemented at the EU level? So that was all for me, and I remain available for any question that you have. I hope I was not over the 10 minutes.
It was perfect. Thank you very much, Claire, for clearly mapping the scale of informal care in Europe and the consequences of taking up the role of informal care and remaining invisible. So I'm afraid we have experienced a technical issue. If this is the case, apologies. It happens with online events, obviously. I hope it won't be repeated. So our second speaker is Dr. Valentina Hlebik. She's a professor of sociology at the University of Ljubljana. Dr. Hlebik is a highly respected researcher with extensive experience in long-term care, social policy, and informal care. She has led and contributed to numerous national and EU-level research projects. Her work has been widely published and recognized, including a recent National Research Excellence Award for work on long-term care and dementia. In her presentation, she will focus today on different ways of looking at the economic dimension of informal care, highlighting why these perspectives are important and how they can contribute to broader policy discussions and decision making. Valentina, please go ahead.
Thank you. I will now share my presentation. Is it visible?
Yes, at least I can see it.
Okay, perfect. Thank you. So today I will present a few methods of evaluating or estimating the economic value of informal care. And after the initial slides, I will also tell what are limitations of my presentation. Okay, because I'm not an economist, I'm a sociologist. So I might have different opinions or research which is not up to date. Okay, so what we understand already that informal carers are not a homogeneous group. So this is not an adult person with employment. Rather, care is provided by children, adolescents, young people who are most likely in education. Some are already in professional training and some not. Then we have adults with work and family responsibilities. And we also have older people also with family responsibilities. So carers are also women, men, they can be in school, employed, retired, and also informal care has many different phases. So one can provide care an hour or few hours per week, or in extreme care needs, this could also be 24/7 responsibility, which is quite a lot. And also care recipients, family members, they differ. They can be children, they can be adults with disabilities, they can be adults with certain health conditions, and they can also be older people. So care recipients are also not a homogeneous group. So together with recent human experience like COVID, economic crisis, estimation of the value of informal care becomes quite important for two reasons. For Eurocarers, as we advocate for informal carers and their life conditions, it is important for us to know how to argue how much informal carers contribute to the economy of care. So this work is not free of charge. Maybe some people would think that it's really appealing that in interventions around healthcare, it's very fine to reduce costs by, let's say, early admission of patients from hospitals to their homes, and where it is expected that their family members would provide care for a certain amount of time or for a longer amount of time. So also, the movement to move aging from institution to aging in place is also not completely without costs, because we assume that we can provide an older person or a young person with care needs high quality of life, also at home. So let us ask a question: is informal care provision free of costs? Of course, it is not. Now, there are costs to informal carers, and there are costs also to their workplaces, school places, social engagement, and even to their health and financial security. So, if the care needs evolve slowly over time, this is the typical scenario. First, as an informal care, you replace leisure activities with care. Then, if the care needs increase, then you withdraw from other social relationships. You maybe decide to reduce work hours permanently or for a short period of time, or you can also leave employment completely for a certain period of time or for good. So this, of course, even if it is gradual, it can also be sudden experience of extensive care needs. So this kind of experience and replacing other activities with care will, on the long run, have detrimental effect on informal carers, on their health, social security, financial security, professional identity, and social contacts. So the cost of providing care at young age are very difficult to evaluate. I mean, can we really estimate or say what are the lost opportunities in education, professional training, social development? And these are things that will affect young person throughout their whole adult life. So we can see, Anne, that this is quite a complex issue. And today I will present three families or three types of methods how we can estimate the economic value of care. However, this work is based on a summary of work conducted for Eurocares in 2017 and 2018, together with Sophie Sess and Stacy. And Sophie is an economist, so her contribution to this summary report is really huge. So I'm here only to report on this report that we prepared jointly. And I will also reflect it from the point of sociologist with a lot of methodological experiences. And at the end, of course, also through lenses of informal care, as I'm also an informal carer of a child with disability. So there are three types of costs involved when we speak about value of care. First of all is the caregiving labor. Second are out-of-pocket expenses. And third are employment consequences. And these employment consequences can be observed on the level of the individual, the family, the work institution or company, and then on the level of society as a whole. So you have many, many different levels of consequences. Okay, so we distinguish between two big families of methods, and the first one is called the revealed preferences methods. You have two variants, and then you have methods where you ask people what they want. And you ask people what they want in a very specific way. And also in these methods where you ask people what they want, you also evaluate their subjective well-being, one way or another. So these are the big methods, and let's go into the characteristics of these methods and what is needed to estimate the value, economic value of care. So for the opportunity cost method, for the revealed preferences methods, you have two types: opportunity cost, which is called the input approach, and the output approach, which is the proxy good or the replacement cost method. So in the opportunity cost, what you need is a few types of information. You need the amount of hours of providing care, and you need to have information about the wage of informal care. So here, the cost of care is estimated through wage of informal care, which is supposed to be active on the labor market. So this first method, it's a quick shortcut. It's fairly easy to estimate, but it does not take into account carers who are not active on the labor market. That would be young people, retired people, and unemployed people. So there are some shortcuts, but basically these groups only, this estimation can be used only for working carers. Now, the second method, which is also quite easy to employ, is that you have a figure about hours of providing care, and then you estimate the costs or the contribution of this care by finding out how much a professional care for the same amount of hours would cost. So this is the replacement, how much this would cost if the informal care was replaced by formal care. This could be done also for young people, for retired people. But of course, on the first glance, this is simple estimation, but it's not so simple if you actually if you actually try to evaluate different types of activities and you try to estimate how much different type of activities would cost, because you might have different professionals involved with different costs. So this is the second of the revealed preferences methods. Now, the stated preferences methods differ from the previous one is by the way that you actually ask people a series of hypothetical questions. And these hypothetical questions would look like this. Suppose the person you provide informal care to needed an additional hour of care per week and government would pay you for it. How much you would minimally want to receive from government to provide this additional hour of care? So this is the VTA model, and you have also the VTP model that would be measured. So that would be willingness to accept money. And then there is another type of VNet, which is called willingness to pay. And it goes like this. Suppose it were possible to decrease your informal caregiving by 1 hour per week, and someone else would take over this hour so that the care recipient would still receive the same amount of care. How much would you maximally be willing to pay to have this hour taken over by somebody else? So this is the hypothetical situation that informal carers must estimate. So 1 hour of care. Of course, together with this information, you need all kind of other information, like what is the salary of the informal carer, whether they are employed or not, what kind of tasks are they providing, how these different types of tasks are evaluated, and so on and so on. So this method, first of all, you have to think about a very hypothetical situation, which is called 1 hour of care. And then to calculate the costs, you also need quite sophisticated econometric modeling, which not everybody can do. So this one is quite complicated, and you basically get different numbers for different type of carers and different type of tasks. And then the third family of methods would go like this. You have, again, the vignettes like before, but also you ask people about how they feel. The first models that were employed used only very simple question, which was about happiness or satisfaction with life. So the logic behind it here is that you need to estimate the amount needed to compensate 1 additional hour of care while maintaining the same level of well-being measured with a simple indicator. So it's really possible, again, to make things very complicated if you have several questions about well-being, and of course you evaluate quite complex model with this one as well. So what is useful and what is not? Each of these methods have advantages and disadvantages. And in fact, they address different questions regarding the economic value of care. Revealed preferences, that would be, we talk about the amount of care you are providing right now in the past month or year. This is simple to use. But on the other hand, you don't ask people whether or not they would be willing to provide more care or less care. So the first variety of this method is only used for employed carers or can be used for employed carers, whether the proxy goods or replacement method can be used for everybody contributing to the care economy. This is about the first family of the method, the stated preferences method, and the well-being methods ask also questions about what you would like to do in the future. I would say that answering a question about 1 hour of care is really, really difficult because the care itself is very complex, and we are very complex beings, and our care recipients are also very complex beings. So I would say that answers to these kind of questions are still very hypothetical, and they would not actually be informative for the monitoring of the actually change in care over time. Okay. based on the research done up to 2018, I would say I read a few of these articles and I was uncertain of how stable these methods actually are. I mean, methodologically stable. Lots of the estimations actually depended on the question and response formats. There was quite a lot of non-response, which I'm not surprised as first of all, as a methodologist, and second of all as an informal carer. So I was still considering whether or not I could answer a question like that. And I would assume that most likely I would be among the people who would not respond to these questions. So I would provide non-response. Why? Because when I think about care, I more often first think about the care need of the person who is involved, who is receiving care. Secondly, I don't think about hours. I think about specific tasks. And I also think about whether or not my care can be replaced by formal care, and whether the care recipient would receive the same quality of care. It could also be that informal care would provide care of lower quality as opposed to the formal care. So we need to consider quite complex situations, which I don't think can be answered to a question of 1 hour of care. Also, considering the amount of work and complications involved in the second and the third family of evaluations, I would say they are very complicated. And I'm not sure that we can make them even more complicated. And I doubt that with quantitative approaches, we can actually, which are not that complicated, we can get very valid and reliable estimates because of these complications. So this being said, I think that these models, all of them are useful, but they also, all of them have disadvantages. So it depends on the purpose. So if I would say, if I have to decide today to support Eurocarers with an estimation of the value of care, I would use the first family method. That would be revealed preferences, without actually bothering to invest all the work and collect a lot of complicated data, do a lot of complicated modeling to get an estimate, which is maybe artificial. So that's from my side. Thank you.
Thank you, Valentina, for this informative presentation, a way translated unpaid care into socio-economic terms. Thank you very much. I would like just to remind the audience, if you have any pressing questions, please use the chat to put them, and we will address them in the end. Now, moving to our third presentation, our third speaker is Mr. Evangelos Koutoummanos. I hope I pronounce it relatively correctly, your name, also known as Angelo or Angelo. He's the founder of Noisy Greece. Angelo is a social worker with a long-standing experience in disability sector, program coordination, and policy analysis. He founded Noisy Greece in 2004, which has become since a key national resource hub on disability issues in Greece. He has also held leadership roles in major disability organizations and was recognized nationally for his work, particularly during the COVID-19 pandemic. In his presentation today, Angelo will explore how gender norms and stereotypes shape care work, contributing to its invisibility and economic undervaluation, and also how these dynamics continue to reinforce the gender care gap, drawing on recent EU-level data and research. Angelo, the floor is yours.
Thank you, Svetlana. Thanks, everybody. Thank I personally would like to thank the hosts for this invitation, and I'd like to just take the opportunity and cover a subject which is extremely relevant to what you've heard right now, but you should try now to consider that there is a special part of informal care that actually applies to one of the two, if we try to see the genders as being two, one of the two genders in particular. So I will try to link this to our work at Noisy. As Svetlana said, I'm a social worker, so I'm really interested in what the services are actually providing, so how the services are evolving. One of our basic work in Greece is that we are the primary partners of mapping the disability sectors, both in private and public sector, and providing information to the government and other bodies that are interested to know what it's out there and what's not. So we look at gaps and overlaps in services for people with disabilities. Even if we map all services that provide something for people with disabilities, we would still leave a very important number of services outside because it's informal. What I'm trying to say is that most of the care provided to people with disabilities is actually provided informally. This happens in countries like Greece, in countries like Italy and Spain. It happens less in other countries such as Germany, and even less in other countries such as Sweden. So in this presentation, I would like to focus on this particular aspect of the gender equality between informal care. So I'll start sharing the presentation. Now, just a very brief note here. Our organization has actually partnership with the Republic of Cyprus, and we will be delivering their 5-year strategic plan on disability on an easy-to-read mode, on a easy-to-read document. So in this presentation, I've actually tried to do something that may help some people read better. So you will see one slide that will have graphics, and then the next will have text only. And I'll be very happy to receive comments if this works for you in the chat below. So let's look at the gender dimensions of informal care for people with disabilities. Know that it's very difficult to actually come up with a figure as to how much money is actually spent on informal care. And it's actually not money that we spend, but it's actually money that we don't make. So people are actually providing some work, but they're not receiving anything back from it. Now, what we know as a fact is that nearly half of the population in Europe, 45% of the EU population, actually provides some form of informal care, basically to people with disabilities, but not just disability. We know for a fact also that women are significantly more likely to provide that intensive informal care on a daily basis for a different number of needs, from medical management to hygiene. So we also know that the reality is that in Europe, informal cares can be up to 80% of all long-term care. And we also know that 73% of these carers are actually women. Now, new data provided in 2025 have actually suggested that between 147 billion to 220 billion euros is actually lost in earnings every year by the people who provide this informal care. And as I said, they're primarily, by 73%, as we know, women. So there is a thesis here. There's something that we can try to understand why this happens. There is something that I would like to call the naturalization. It's sort of a let's just say an informal theory of informal care are actually devalued. If we look at the same data from the Gender Equality Index in 2025, we will see that 37% of women are performing what we call intensive care, which is more than 5 hours per day. And this could be one of the reasons why women are 3 times more likely than men to be pushed out of the workforce, either by working less hours or by just, retiring entirely. If we look at week hours, we can say that 26 hours during a week is spent in unpaid caregiving by women. And if this compares to men, it would be 9 hours. So there is what we call, so there is what we call an invisible labor here. And because care is provided so often by women at home, it is very frequent that people can see this as a charity, as a giving from the heart, not as a labor, as giving from love, let's say. So it's not an essential part of our social or our economic fabric in social care. And there's also what we can call a skills myth. There is a myth that this work is natural for women. No particular skills are required. Whereas in fact, if you look at the skills required to provide care for an individual that's disabled, you would have to look at patients, you would have to look at management of medical needs, you would have to look at emotional intelligence, and of course, you'll have to look at commitment. Now, these are very important skills in the workforce, and they're really often devalued when we're looking at informal care to disabled people. So what happens is that we have a gendered cycle. We have a cycle where women are providing the care, they are unpaid. We look at their work in devalued terms as something that, this is just what it is what it is. And we are no longer reinforcing the idea that this has to change because it doesn't have a real economic value. Now, in the next slide, I would like to talk about what we can call as double invisibility. If we were to achieve an equality between men and women in providing care, we would first need to address this domestic balance that I talked to you about. So we need to look at it like it's an iceberg. What the policymakers are seeing is the top of the iceberg, and this would affect their ideas and plans about social security budgets, about employment statistics, and other important figures in social policy. What's under the level of the sea is basically what we cannot see very clearly, and that's an 80% of informal care versus 20% of formal care. And we can't also look at the billions of euros in value every year that are not accounted to the GDPs of the countries. Now, we have other effects because of this iceberg effect. For example, we know that based on EU statistics, 25% of gender pension gap effect. So the idea that somebody works but doesn't actually get a pension for it would affect women more likely than men. And also, as we said before, women are more likely to leave the entire workforce, the workforce entirely because of the need to take care of an individual. Now, this leads to an economic strain in families. It also has a health toll on women. It's a burden. It's not just a financial burden. That's what I mean. Female caregivers will face higher rates of health strain or social inclusion because of the work that they provide. And finally, I would like to focus on the isolation issue that can happen in countries like Greece, Italy, and Spain, where caregiving by disabled individuals is also common as well. So the disabled individual has got a double identity. They're the clients in terms of receiving services for disabled people, but they're also caregivers to other people with needs. Now, if you look at it from a gender perspective, women with disabilities in Greece are very likely to become caregivers themselves while having a disability. If we were to look at what we can do about this, I think we need to listen to a report that was published recently that actually said that if we continue to proceed with whatever we're doing right now and try to shift the balance of gender inequality between men and women, it will take around 60 years, 50 to 60 years. And I'm just putting a little note here. The statistics for my presentation will be available to anybody who's interested, because I will forward everything to Svetlana, and then if anybody needs, they can find information about it. I think, and the Equal Care project is really important in this aspect. The main goals should be three particular things, and this will be the closure of my presentation. First of all, we need to break the norms, and we need to involve men more in caregiving. So we actively need to encourage men to take part in caregiving roles and redistribute the burden between men and women. And if I can put it in plain words, I would say that this is a collective social responsibility. It applies to individuals, it applies to service providers, and it applies to the state as well. We also, secondly, need to break the glass ceiling. What I mean by that is that women find it more difficult to achieve leadership roles within society. But that doesn't really seem to apply in caregiving. What can be done about it is that women who have an extensive expertise in caregiving can actually become leaders in structuring services for individuals in need. And finally, a shift needs to be made in the state level because of the fact that we need to accept, if we accept the fact that we have a very large amount of money being unspotted, so we have a lot of a big service being provided that's not being paid. If we start to take this into account, this will really affect the money being spent on social provision and social welfare by the EU state. So in this sense, we really need to change how we look at informal and formal care and try to bring everything to the formal side. So if I was to just make one final thought about it, and I hope I'm not over my time, is I would say that if we support carers, then the society will also thrive. But we have to make the invisible visible. And we have to remember that a very particular sector that applies to people with disabilities may include people, and especially women, that have a double identity, which is a very big burden for them, being disabled themselves and caring for other disabled people. Thanks so much.
Thank you, Angelo, for so clearly unpacking the gender assumptions that still underpin care work across Europe, and for highlighting their economic and social consequences. Our final speaker today is Emma Colau, representing Acufade. Emma is a legal expert and social rights advocate from the Canary Islands. Emma works both as a manager at Acufade, one of the region's leading organizations supporting people in situation of dependency and their families, and as a director of the Observatory of Social Rights of the Canary Islands. Emma's work focuses on dependency care, social rights, and strengthening public support systems. In this presentation, Emma will share practical national examples of how carers' visibility can be raised and how support systems can be strengthened in concrete and meaningful ways. Emma, you have the floor.
Good morning from the Canary Islands. Before we begin, I would like to thank you all for taking part in this space, and of course to thank also Svetlana and everyone involved in organizing this webinar for the dedication, the work, and the care that a space like this requires. I really appreciated listening to the previous speakers. I found their contributions very interesting. Before I begin, please excuse me if you were expecting a visual presentation. I don't usually speak English in my day-to-day life, and in these 10 minutes, I prefer to focus on getting through everything I want to share with you without getting overwhelmed by the language. As some of you may know, today I'm representing Acufade, an association that has recently marked 20 years of work building alternatives, improvements, and ways of supporting those who provide care. And of course, providing support to people in situations of dependency. Over this time, our work has a focus on accompanying, sustaining, and organizing at the community level all those voices of care that are so often confined to the tasks that keep life going, without the possibility of social community and why not also political participation. This is the reason we were founded.
Interrupt. Sorry, I think we cannot hear you very well. I'm looking at the chat and there is a bit of echo. Sorry to interrupt you.
Yes, microphone. Maybe I don't know if you try without your headphones, so if there is another device in the room.
Explore just a minute. No, it's not it's the same.
It is the same.
It's the same.
Now?
If you go
Can you?
to down at the left bottom to audio. And
Yes, I am. I'm there.
Choosing up a pause for the mic.
We
Yeah,
can't hear you now, Angelo.
Now? Sorry? Better.
It
That's
seems
great.
better. Yes.
Okay, perfect. Sorry. The reason we were founded as an organization and the right to care is the goal for which we hope we will be not needed in 20 years. That would mean the right basic system is working. Today, I want to speak about long-term care and raising the visibility and also supporting carers. I will use Spain as a case study, not because Spain is unique, but because it shows very clearly what happens in Europe when care is treated as a promise rather than a guarantee. Because care is not just a sector, care is where institutions become credible or where they become suspect. Care is where the social contract becomes real. Spain has had a national long-term care law in 2006. It recognizes access to care supports as an enforceable right implemented through regional administrations. Let me explain the model without acronyms. First, a person applies for an official assessment. Second, the administration evaluates the level of support that needed. Spain uses 3 levels. Think of them as moderate, severe, and high dependency. And third, the person receives an individual care plan, home help, telecare, day centers, residential care, personal assistance, or sometimes a cash benefit when care is mainly provided by family. On paper, this is a framework of rights, but rights are not measured only by being written down. They are measured by whether they arrive on time. And here is the problem in one number. The legal maximum for processing is 180 days. Yet in March 2025, Spain's average processing time was in 338 days. When care arrives almost a year late, the system does not simply delay, it selects. It selects who can hold on, who can buy a private solutions, who can stop working, who can break, and delay is not abstract. In March 2025, it was reported that people died while waiting either for assessment or for a benefit already recognized. So this is not only an administrative issue, it is an ethical fault line. Even where a general care system exists, some realities overwhelm standard rules. Consider amyotrophic lateral sclerosis and other irreversible high complexity conditions. In advanced stages, care is not occasional help. It can mean continuous supervision, specialized support, real condition between health and social care, and intensive home-based provision. If that is not guaranteed, what it is it at risk is not only quality of life, it is life itself. Spain adopted Law 3/2024 to improve quality of life and access to specialized services for people with ALS and similar conditions. Then in October 2025, Spain adopted Royal Decree Law 11/2025 to strengthen long-term care system for these cases. It includes something very concrete, a public guarantee of continuous, specialized 24-hour supervision and care in advanced ALS. It also creates a category often described as extreme dependency beyond the standard highest level. And in early 2026, criteria to access that category were published. Here is the political lesson. When care is regulated only in generic terms, what falls through the cracks is not marginal. What falls through is often the most urgent, the most resource intensive, and therefore the most devastating for families. And even after reforms are approved, implementation can still be trapped by the administrative capacity and bureaucracy. So legislation alone is not enough. What matters is enforceable delivery. Now I want to name the figure present in every country, the caregiver. No? Our societies often offer symbolic recognition. We call caregivers essential. We praise them. We romanticize sacrifice. But symbolic recognition does not pay rent. It does not buy time. It does not protect health. It does not secure pension contributions. And it does not repair broken careers. When the people systems arrive late or arrives weak, care is reorganized at home, and the structural reality returns. Care falls disproportionately on women and also on community networks where many LGBTQ people have historically provided care with less institutional support and often more precarity. This is crucial. The absence of material rights for caregivers is not a neutral omission. It is a concrete way of distributing social costs. And those costs show up as poverty, as job loss, as chronic exhaustion, as isolation, as a life put on hold until it passes, even when it does not pass. Sometimes we speak as if the lack of public coverage is simply a gap. But the gap does not stay empty. It fills up with markets, with debt, with private solutions, with urgency turned into a product. This is not a moral accusation. It is a description of a logic. When rights are not guaranteed, the market manages exposure, and the management can be extractive. It extracts time, often unpaid or underpaid. It extracts health, bodies worn down by carrying what the system should carry. It extracts future, interrupted careers and reduced life chances, and it extracts community, because isolated care impoverishes neighborhoods and towns. So the question is not only what care costs. The question is what it costs not to guarantee care properly, because the cost exists anyway. It is simply paid by different bodies and different homes. When a society does not materially recognize care, the cost does not disappear. It is displaced. One of the clearest displacements in Europe is care migration. Transnational chains in which migrant workers sustain care in receiving countries, while their own families remain far away. In Spain, as in many European countries, this is particularly visible in domestic and care work, where the share of foreign-born workers is very high. And this raises a simple European question. Do we want a welfare model sustained by imported inequality? Do we want to solve care through precariousness by shifting who bears the burden? Because without universal rights and real guarantees, care becomes an economy in which some life sustains other under asymmetric conditions. And the asymmetry resembles a colonial continuity, even if we do not name it. Now the bridge between Spain and Europe. Europe does recognize care as a right. Principle 18 of the European Pillars of Social Rights affirms the right to affordable, quality long-term care, especially home and community-based care. The European Commission launched the European Care Strategy in 2022, and the Council has adopted a recommendation on access to affordable, high-quality long-term care. But the key word is recommendation. In the European Union, care policy is still largely national and regional competency. So we often get a dangerous fracture between promise and experience. Europe declares values and rights, states translate them into laws. But if those laws become stuck in delays, underfunding, territorial inequality, bureaucracy, people do not experience European rights. They experience abandonment. And when the abandonment touches care, it touches the core of democracy. Because distrust does not start as a theoretical debate about Europe. It starts in the body, it starts in the person who cannot work because they care, in the family waiting months, in the endless administrative pilgrimage, in the sense that life has become paperwork. In other words, care is where Europe's everyday legitimacy is tested. I will close with a simple idea. Recognizing the right to care and to be cared for is not enough. It must be materially guaranteed. Spain has had a legal framework in 2006, yet processing time show how a right can become a different promise. And the need for specific reforms for ALS and high complexity conditions show what happens when regulation stays generic. The most urgent realities are the easiest to leave behind. Europe has principles and strategy, but what is still missing in many contexts is the hardest part. Turning commitments into a binding basket of material rights. What do I mean by that? I mean guarantees that any person can claim in practice: sufficient home-based support, respite and rest for caregivers, personal assistance when life requires it, a real coordination between health and social care, economic and labor protection so that caring is not a pathway into poverty. If we do not do this, the system does not only fail care, it fails the social contract. And care becomes the place where citizens learn to distrust. Because when a society does not guarantee the right to care and to be cared for, it does not only produce suffering, it produces disbelief, and disbelief is the ground on which the future rebels. Before we close, I would like also to put forward an alternative that ACUFAD is working on developing with the intention of demanding its implementation by the Canary Islands administration as well by the state. We propose revisiting the core principles of what the World's Women's Strike called a care income. We have wanted to take this idea further and develop it by giving its implementation a new term. Let me explain. We propose an income, not a benefit, set at the level of the statutory minimum interprofessional wage, in force each year, which could be requested by any person who is responsible for providing care to another person. This income would include social security contributions and would count towards the recipient's employment record. It would be linked to a specific training pathway to guarantee knowledge, skills, and occupational safety for those who apply for it. Once their caregiving relationship ends, these people will have gained training and qualifications that would allow them to join a human resources pool aimed at delivering care services through public care companies. All of this would be done not to replace, but to complement the recognition and provision of specialized services for people with long-term care needs. The impact of these measures on the social and circular economy make it possible not only to recognize economically and professionally people who are currently invisible, but also to build economic models designed to improve living conditions and provide material rights. Of course, I'm summarizing a very complex measure that requires substantial technical work in the background, and I apologize for offering only these broad strokes, but we are talking about something fundamental. It is possible to build alternatives. It is reasonable, and if you allow me, in these difficult times, we must believe it can be done. I wouldn't like to finish without saying otherwise my colleague Pribas would never forgive me. Of course, I'd like to invite you to the third International Congress on Care that we will be holding on the island of El Hierro here in the Canary Islands. We will share the information with you. Please consider yourself warmly invited. Thank you very much.
Thank you so much, Emma. Thank you very much again to all our speakers today for those rich and complementary contributions. We have heard today how extensive and essential informal care is across the EU, how its economic value can be made visible, how gender norms continue to shape care responsibilities, and how concrete practices at national level can improve recognition and support. Now, this leads us directly to the final part of our webinar today. And I see that we have 10-ish minutes left. So I will swap the initial idea of having first an audience poll and then moderated discussion. So I propose that we start with the moderated discussion so the audience have the chance to pose their to send their questions to the speakers. I don't see any questions on the chat for the time being, but that doesn't say that there are none. So let's start with a few questions from the audience. Later, if time allows, and for those of you who are not in a rush, you can stay and we can go back to the poll, which I promised at the beginning. The floor is open for questions from you. Please tell your name, the organization you represent, and to whom the question is addressed. No questions? Everything has been clear? Okay, then allow me to address a question to Claire and Valentina. What is the biggest risk if policymakers continue to ignore the economic value of informal care?
I can go first.
Valentina, thank you very much.
So I would say that the first thing comes to mind is the underestimation of the actual cost of care. If we only count in the formal care, that is what is monitored at the moment, it means that we are disregarding the in-kind contribution of informal carers. And this then would have, I would say, a strong effect at certain point in time on whether or not people are still willing to put their heart and time into informal caring, especially if they don't have a safety net. And a safety net is provided by policymakers by regulating the safe exit, partial or limited, from the workforce. It can be with contributions, it can also be unpaid, but if we want to keep providing informal care, we need to offer informal carers safety on the labor market. And also, we need to think about young carers and people who are already retired and are providing care. Especially with young carers, I see a big issue because they are mostly invisible. And I don't think we can today validly estimate the risks they are taking as young people who should be investing into schooling and professional training and in personal development. So there I see a big issue, and I don't think I have an answer. But in terms of adult people who are employed, I think that safety is crucial. And it should not be disregarded. We cannot assume that people will continue to provide care without recognition and without safety, financial and otherwise. So that's just the first impression from my side. Claire, go ahead.
Yeah, it's a wide question. I think if we don't recognize, if we keep not recognizing the value of informal care and the impact of informal care, I think first we are going to still design policy in the area of employment, anti-poverty, social protection that will be not efficient. I mean, I'm still amazed to see policy aiming at raising the employment rate, which doesn't consider the care issue. So if we don't factor this in terms of what employment people are able to take, I see like in Belgium, we see big reforms currently on access to unemployment benefits and these kind of things that are going to push people into poverty. And I guess many of them are actually informal carers. So that's one point. And also, I think if we don't recognize and support carers and give them a safety net, we're going to fuel the fragmentation of society because many of them are going to be marginalized. As you said, Valentina, some of them from early age. At the other side of the society, you will have well-off people who will be able to buy private services or employ migrant carers. So it's going to emphasize the polarization, fragmentation in society and fuel a lack of trust of people with regard to policy, public authority, and policymaker, which is also very dangerous in the current times. So I think it can have very detrimental impacts on the society in general.
Thank you very much to Valentina and Claire. Do you have questions to any of our experts today? I still don't see questions in the chat. That says that the presentations have been really self-explanatory. Would it be possible to share the transcript of this meeting, please? Yes, we're recording it, so there will be a transcript and there will be minutes from the meeting, from the workshop as well. Welcome. So if there are no questions from the audience, I have one final question to all speakers. From your experience, what is the hardest stereotype to challenge when it comes to informal care? We have a bit of time to think. It can be very short. It can be just one sentence or even one word response. In any case, we are already behind time.
Well, I can start. I think I don't know if there's so many stereotypes, but I think one thing is important is that very often we see informal care relationship as built on love and, I mean, emotional bond, but it can be also underpinned by very difficult relationship, complex relationship, and it can also, if it's not supported and if people are isolated, be a situation where informal care is not chosen and is not psychologically beneficial to both the informal carers and the people receiving care. So it can be very detrimental if it's based on very difficult family situation which have not been addressed or disentangled. So it can be built on culpability or guiltiness or fear or a lot of difficult situation. So this is also to be taken into account.
Thank you, Claire. The complexity of the relation.
You have closed your microphone.
Oh, sorry.
Sorry.
Yeah, I was thanking Claire, and I was asking whether there is from the speakers someone else wants to add something to this.
I would say that from my side, the expectations that the family will be there, I think that this is not granted. Like we assume that it is. We assume that when you discharge somebody from the hospital, there is somebody on the other side that will take this person and care for him or her. And I don't think that's can be expected, you know?
Yeah.
And also, I would like to comment on different parts of care. Of course, part of it is healthcare, part of it is social care, and they are financially evaluated at different rates. And it is assumed that for the healthcare provision, you need specific education and training. But on the other hand, my recent experience with surgery last year was that when I was released from the hospital, I was given one lesson in how to administer injections myself. So, in fact, today, when you are released from hospitals, you are expected to learn healthcare skills on the spot.
Yeah.
So I'm not sure if this can continue downhill, but I don't think we can take informal care for granted. That is there on the other side. Yeah.
Thank you very much, Valentina. Indeed. There is a question. Well, there is a comment on this from Shannon, our new executive director in Eurocarers. She says that I think this is really very point about assuming someone will be there to care for you when you are released from the hospital, with Europe's changing family structures, with more people living on their own. This is really very important. Thank you, Shannon. And there is a question actually a question for Angelo, actually. I know he mentioned that we as a society have a role in helping men engage in informal care. Are there any suggestions on how to achieve this? Angelo, I kindly ask you for a very brief answer because, yeah, the time is up.
Yes, I briefly say that I think this is a matter for everybody. It would apply to people at managers' posts, recruiters, and people who are responsible for onboarding caregivers on an organization. For example, it's something that's always on my mind when I'm looking at CVs and trying to balance the team. The second, I think, which is probably most important, is that I think it's strongly related to cultural differences and cultural upbringing. So it is something the parents and the society overall can affect. It will take time, obviously, but I think we have to look at this from a different point of view. We have to start looking at something from a different point of view. And if we act as if something is there, because obviously we're not just looking at the tip of the iceberg, but we have the means to understand what's happening under the sea level now, obviously. And if we acknowledge this, then lots of our actions at state policy level, at organization level, and also as individuals will change towards that end. It's probably a very idealistic way to look at it, but I don't have any other suggestions at the time.
Thank you very much. Thank you, Angelo. I'm afraid we have to wrap up because our time is over. So we come to the end of today's webinar, and I would like to thank again all our speakers for their insightful contributions, and also for you who participated in the discussion, for your thoughtful comments on the chat and the questions. I would like to say that today's webinar marks the beginning of a broader equal care webinar series, which will continue over the coming months, and they will progressively deepen the issue we have started to explore today. Our second webinar will focus on breaking gender stereotypes in informal care, with particular attention to men's involvement in unpaid care. The webinar will also explore the cultural and structural reasons why women continue to carry most caring responsibilities, and how men can be encouraged to engage more in care, and also what this means for gender equality and well-being. More information about dates, speakers, and registration for these upcoming webinars will be shared with you in the coming weeks. Before we close, a final reminder to please complete the short evaluation survey. I will send to those of you whose email addresses I have. Your feedback is very important, and it will help us obviously improve the future events, and will ensure that the project responds to the real needs and experiences on the ground. Thank you once again for your time, for your insights, for your commitment to making care work, both paid and unpaid, more visible, more valued, and more fairly supported. I wish you a very good rest of the day, and I hope to see you again at the next Equal Care webinar.